Okay, welcome everyone. Give another minute here for folks to sign on, but thank you for joining us early this morning. Hope you got your coffees and avoided some of the freezing rain, icy road challenges in the Northeast. Looking forward to presenting for you all today, and we'll get started shortly. Okay, so you know what? I think we're gonna just jump right in. We are recording and capturing this, and we'll post it online. So those who couldn't make it for whatever reason, we'll get this up for you to review. But I do want to welcome everyone as we kick off our series of shared learning events for the No Diabetes by Heart and Diabetes Inside Regional QI Collaborative. I want to take a moment to thank our founding sponsors, Novo Nordisk and Eli Lilly, and our national sponsors, Sanofi Aventis, AstraZeneca, and Bayer, whose generous support has made this QI Collaborative possible. I also want to thank our colleagues at the American Heart Association for their work and commitment to improving care quality for people with diabetes and cardiovascular disease, our colleagues at the Health Share Exchange for all of their efforts supporting this collaborative through data collection and analysis and for connecting us to their members, and last but certainly not least, our friends at the Jefferson College of Population Health who are hosting today's webinar. Most of all, I really want to thank our healthcare colleagues who, despite all of the challenges of COVID-19, have stuck with us and continue to drive improvements for people with diabetes. And on behalf of all of us, thank you for your personal sacrifices and for your commitment throughout this pandemic. We know it's not been easy, and it really means a lot that we're still able to count on you as active partners in this collaborative. It's been over a year since we've convened this entire group, and I thought I'd wear a tie this morning. It actually marks pretty much exactly a year to the date. It's the last time I wore one. I did remember how to tie it, and I admit it kind of feels pretty normal and nice to wear a tie again. But I may or may not be wearing sweatpants right now as well, which kind of throws off the whole sense of normalcy. So I know I've met most of you attending this webinar, and I look forward to seeing you again face-to-face soon, hopefully by the end of this year, if not sooner. Tie or no tie, but definitely in something other than sweatpants. Before I turn it over to our Chief Scientific and Medical Officer, Dr. Bob Gabbay, just a quick note on today's format and agenda. Dr. Roy Furman, who is the founder of Care Quality Action and National Data Scientist for Health Share Exchange, will lead an in-depth presentation using data we've collected and analyzed across the region, detailing some of the trends and gaps in diabetes and cardiovascular disease management that our quality improvement teams are addressing from our health system partners. And Roy, if you'd advance to the next slide, please. I'll then take a few minutes to kind of preview the upcoming shared learning meetings that are led by each of our healthcare teams listed here. And we'll then take some questions, which you can submit at any time using the GoToMeeting interface. So type those in as they come up, and we'll get to them. We may run a little short on time to answer all these questions, so we'll respond to all of your queries. And depending on kind of where we end with this, we'll potentially do a supplemental video Q&A. Dr. Furman and I and Dr. Gabbay will kind of record some answers to these questions and then get them out to you promptly. I'll now turn it over to Dr. Bob Gabbay, who joined ADA as our Chief Science and Medical Officer in June of last year after leading the Joslin Diabetes Center. And interestingly, if we trace Dr. Gabbay's roots back a little further, he has quite a background here in our region in Pennsylvania, and I think it'll be interesting to hear a little bit about that. And Dr. Gabbay brings an incredible breadth of experience to ADA, including extensive work in quality improvement and population health. So it's been great to get to know him and work with him over the past six and more months. And I'm certainly grateful to call him my boss. So Dr. Gabbay, if you will.
Thanks, Greg, and good morning, everyone. And thank you all for, for your commitment to this really important effort, not only being here this morning on President's Day, but everything you've had to go through over this last year where healthcare has been disrupted in a way that none of us could have imagined. And for your continued commitment to this program, which the ADA really views as really one of the keys of what we do, and it's really about taking knowledge, which over the years, has been an important effort at ADA and through many, many programs, but ultimately translating that into improving care, because that's really what we all want to do, and that's exactly what Diabetes Inside is all about. Greg mentioned my Pennsylvania connection. So many of you may know, I spent 15 years at Penn State. And one of the things that I was really pleased to have an opportunity to do is lead what at the time was the largest patient-centered medical home pilot in the country in Pennsylvania with 150 practices. And we guided them with payment reform and these kinds of shared learning experiences to improve care, and did so quite nicely. And it really struck me as I've gotten to know Greg and the team better, and what Diabetes Inside is about, is it really takes those central tenets of quality improvement and puts it in a way where we move from not just practices and working with practices, but as you're all a demonstration of, working with health systems. So it's shared learning, it's data to be able to see where you're at and what you're doing and how it's improving. It's using some model for improvement, such as PDSA cycles. This is exactly what we had done some years ago in the work that I described. And so when I came to know all of what Diabetes Inside is, it really resonated with me as an important direction for the ADA to go. And that's why the ADA is so committed to this program, so much so that we are now planning to take the experiences that we've had here with all of you and launch another effort in the Chicago area. And our long-term goal is really to replicate this work across the country. So if you have colleagues in Chicago, put in the good work for us, because we're coming to Chicago and we want to use your knowledge, your experience, and be able to spread that more broadly. I want to finally thank the many partners that Greg mentioned in making this work possible, and really thank all of you for making it a difference in the lives of thousands of people and creating a model for us together to be able to impact millions of people with diabetes. So thank you, and look forward to the remainder of this program and the learning sessions and all of the good work that you're doing.
All right, thank you, Dr. Cabay, and Dr. Furman, you are up.
All right, thank you, Greg, and thank you, Dr. Cabay. As I get the sort of the meat of the matter, give you a data deluge early in the morning, so make sure everyone has lots of caffeine to get started here. And let me see if get the slides working right. There we go. So what I wanted to talk about today was really looking at the quality outcomes in the Philadelphia region. And any information I present here today isn't really to say or to judge any of us or any of you and how well you're doing, because the problems I'll present that we see in Philadelphia are across the country. They're universal. They just vary a little bit in degree from place to place. And so they represent both opportunities for all of us to improve care quality outcomes, as well as challenges that we need all of you to collectively to put your heads together and find new ways to work. And we'll talk about this as we go along. Just wanted to start as sort of a reminder of the complex pathophysiology involving genetics, environment, and neuroendocrine systems and other pathophysiologies that contribute to what we're looking at, which is really heart disease and metabolic disease and their intersection or contribution. And this is all, very familiar to us all as clinicians. But from a patient's perspective, they start off initially and pretty soon have a very large and complex team supporting their care. And since most of us live in urban areas, live in urban areas, these kinds of challenges are magnified because all these care providers are often distributed across different institutions, which contributes to the complexity and difficulties of coordinating care. And I just wanted to briefly touch on some of the themes that Dr. Gabe also mentioned. Oh, excuse me. The video is popping up over my slides. Different approaches to care quality. Obviously, all of us are laser focused on diseases, and a lot of our efforts directed towards care quality are towards education and awareness, training, etc. And another aspect is guideline focus, and certainly American Heart and the American Diabetes Associations publish every year very carefully considered and detailed guidelines. The challenge with guidelines, though, is they really don't tell us what to do in the real world when the guidelines overlap, conflict, or are challenging to implement. Another aspect is looking at policies, and that's something a lot of us don't deal with directly, but we deal with indirectly as the consequence both of local policies as well as state and federal policies. And there's particularly in chronic disease, a wide focus on community efforts. And after one of the talks at Jefferson Population Health, one day I looked up just in the Bala-Cynwyd area in Philadelphia, how many community nonprofit groups were there to serve our needs. And I got a list of 1,000 from my search, and it was overwhelming. And so how do we coordinate all that energy and resources together to focus on the outcomes of our patients? So our answer as Diabetes Insight and as quality improvement is we really need to look at the big broad picture, at the processes that underlie all of these different focus areas and how they coordinate, and figure out even new ways to optimize processes. And just to take a very mundane example, there have been many problems with process over the COVID period, and the most recent one, which isn't directly COVID, but exemplifies what I want to talk about, is the problems with the Postal Service. We all expect the Postal Service to deliver things reliably, consistently, and we also expect it to provide a consistent level of service. So that really gives us sort of 2 points that we all judge outcomes by, and the problems of the Postal Service are process. And so we're going to see how that translates across the medical perspective with respect to cardiometabolic disease. And what froze again? So I'm very big on control charts, or what I like to better describe as process behavior charts. And I'll show you a lot of them throughout this talk. But we're all used to looking at basic statistics, although process charts really kind of condense all those statistics into a nice visual representation. So we can look at means or standard deviations, and we know as we do these and sample every time, there's a little bit of variation over time. And so how can we look at this variation over time for both consistency and standards? Well, we can draw a center line that represents the mean of the mean, the standard error of the mean, and we can draw 2 control limits. And those control limits help guide us. When do we see real changes that are occurring that are either clinically or at least statistically significant, and which changes may just be day-to-day and week-to-week and month-to-month variation. And I wanted you to note that the upper and lower control limits are at 3 standard deviations. So they're broader than what we typically use in clinical outcomes, where we use 95% confidence intervals. These are 99.7. So when you're outside the control limits, it's much more likely that something is going on. And as we plot things over time, as I said, we would like to see consistent processes, and so we like to see fluctuations about the mean. And how can we use these process control charts to judge clinical care? Well, we can look at clinical variation or population outcomes, consistent and predictable, and more importantly, do significant subpopulations have similar outcomes? Because we want equity in outcomes for all patients to the best of our ability. And on the vertical axis, we can judge, do these clinical outcomes achieve the clinical standards or the guidelines that we set both for ourselves and set collectively as a profession. And as Dr. Gabay mentioned, with PDSA cycles, we want to know, do our change efforts actually impact clinical outcomes? And how do our change efforts, are they effective, or have additional change outcomes that we've tried to improve clinical care? Have they caused improvement or regression to poor standards of care? So let's get to the populations we've surveyed. To date, we've looked at, over the years, a large number of healthcare systems, mostly in urban areas and distributed across the country, ranging from healthcare systems that live in high education, high income catchment areas to safety net hospital systems. And as I said, across the country. And unfortunately, we had to travel to Hawaii a number of times to see how things were faring in the South Pacific. For those of you who are currently not in the Philadelphia East Coast area, you'll appreciate those trips. So we've started our original look at Jefferson, and now we've returned to Jefferson, and we've added in Temple locally, which we'll talk about today, and we're about to look at the data in northern New Jersey in the Hackensack system, but we'll focus on just the findings locally. But as I mentioned earlier, the gaps and challenges we see are universal across each and every of these healthcare systems, and we'll show some outcome data for Parkland and Tulane near the end of the presentation. So how did we go about selecting patients locally? Well, we went to the Epic EHR systems, and we requested that any patient with one or more of these diagnoses was part of the population set. And this obviously drew a pretty big cohort of patients. And you can see on the left side, the approximate numbers of people with hypertension, diabetes, or heart disease. And for those, when we talk to the individual healthcare systems, we can break this down even further and show what all the constellations of comorbidities are, but we don't have time this morning for that level of detail. So from our two healthcare systems, we've gotten 35,000 and 80,000 patients from both of them, and had either a 9-year perspective or a 5-year perspective, with millions of lab tests and millions of prescriptions, literally. So let's just quickly look at the demographics. In the top part of the chart, we just showed that we had about 11,000 patients at Temple that had a type 2 diabetes diagnosis throughout that 9-year history, or almost 18,000 at Jefferson through the 5-year history. Both populations had similar ages, similar gender and racial breakdowns, except for the fact that Temple has a higher Hispanic population than Jefferson sees, and a somewhat lower commensurate amount of patients from the white population. Below, we looked at how these patient populations changed over time, and this shows Jefferson. Temple is similar, and they're fairly constant. But you'll notice where I drew the vertical line in the charts below that there was a sudden shift in Jefferson from an average age of 58 to approximately 61. And I'm assuming this either represents a consolidation of practices, which all the healthcare systems in Philadelphia have undergone, or shifting to multiple EHR systems into one EHR system. But otherwise, the patient populations maintain temporal consistency. And this just looks at Temple of the patients with diabetes who are seen every month. What proportion of them are tended to by internal medicine, family medicine, cardiology, endocrinology? And again, it's relatively stable. But we can see, for instance, in cardiology, turn on of the cardiology practices sometime after 2010 before it stabilized. But what's interesting about this is a patient with diabetes is likely to see a significant number of cardiologists or a significant number of endocrinologists in the system. So that represents both opportunities and challenges for care coordination between the primary care providers and internal medicine, family medicine, and the specialty care providers in the other departments. So the first thing we wanted to look at was A1C testing. And the reason we looked at this is in every system we went to, we showed a scatter diagram of the A1C level of the patient along the horizontal axis and how long it was between test intervals on the vertical axis. And everywhere we saw this widespread and scatter, although the guidelines from the ADA to testing recommend quarterly testing in those patients who are needing changes in their medications or who are in poor control, and at least semi-annual testing in everyone else. And at first, we might hypothesize people in poorer control are less likely to get follow-up tests. And so there's a regression line through the middle that shows only to a very minimal degree is that true, or people who are in good control are likely to skip test. So one of the healthcare systems, Tulane, decided to focus on this as one of the major efforts for improvement. And they were the first one to look at it. So we reported a paper on this, but we did the exact same look at both Temple and Jefferson. And this is the results I think from Jefferson of the time between A1C tests. And this is shown in a survival analysis or time to event curve. So if we look at the vertical axis, it's the proportion not tested by the time axis, the days between tests. And it turns out that about 50% of the patients do not get tests as frequently as every 6 months or better. There's a little bit of a racial disparity here that is statistically significant, but when you look at the actual difference in time, it's only about 3 weeks, so it's probably not a clinical difference. But 1/2 of the patients are not getting tests at the recommended rate. So what is the consequence of this? Well, this again is local data showing that the relative change in A1C between the two visits. If you're tested at 6 months, that you see you get about a 3.5–4% improvement in A1C, and if you're tested at 6 months, you're at about a steady state. But as the time interval increases, the relative change in A1C is actually trending towards worsening values. And this graph is identical more or less across Temple, Jefferson, and Tulane. And when we wrote the paper, there was I patterned this graph after a paper from the United Health System in the UK, which showed a similar trend across the whole country. And so this is a very simple and seemingly simple process measure of ensuring our patients get tested frequently enough, but yet the half of them don't, and it leads to poorer outcomes than could otherwise be achieved. And I won't show it, but at Tulane, where they did focus on this, they were able to make in about a year's time a 20% improvement in reducing the proportion of patients who had delayed testing. So let's look at another aspect of care quality, and we'll label this the ABCs for A1C, blood pressure, and cholesterol control. So this is the overall outcome of the populations where patients with type 2 diabetes at Jefferson and Temple, and you see they're almost identical in outcomes. I think it's 18 and 19% with A1Cs above 9, approximately 70% of people with A1Cs below 8, and similar proportions at the other levels. But if we look at it over time too, we see that in 5 years over Jefferson and 10 years at Temple, that the individual outcomes are invariant, despite any ongoing efforts to try to improve care across either healthcare system. And if we look at the proportions of patients with poor control, i.e. A1Cs greater than 9%, at Jefferson it was 17%, and just ever so slightly worse at Temple at 19%. And there's we thought initially there might be some trends in the Temple data, because it looks like from maybe mid 2015 through 2019 that there was some evident improvement, but none of the endocrinologists said there was an explicit targeting of change, so that didn't turn out to be true. If we looked, however, at outcomes by race or gender, that we see in Jefferson, the Black population has almost twice the outcome of A1C, 21% above 9, than do the white population and the Asian population. And Hispanics are even slightly worse at 22%. And this is pretty much identical at Temple also. And across the country, the racial disparities vary a little bit in terms of magnitude, but they're almost always present in all systems. And fortunately, though, in this particular measure, that the gender disparities aren't an issue. If we look, however, at A1C as a function of age, this is something every endocrinologist knows, but every clinician is surprised when they see their own data that the strong downward trend of A1C as a function of age. And if you, the vertical red line I put on the graph is the median age of the populations with A1C. But we see that half the population is really above the mean, which is to be expected, but you don't realize how strongly inclined it is. In other systems, we've seen, every system, in fact, we've seen the same trend, the only difference being in populations that in economically more or less impoverished areas, the trend may be a little bit flatter, but nevertheless, it's there. If we look then at another progenitor of poor clinical outcomes, BMI as a function of age also shows a very strong downward trend, starting at about age 40 and getting better with older age. But conversely, looking at the other way, the young population at 18 gradually increases their weight until about age 40 before the descent. And it's interesting whether or not this is an age-related phenomenon or a time-related phenomenon with changes in dietary or environmental habits, and something that is certainly worrisome in any event in trying to reduce cardiovascular outcomes and reduce cardiovascular morbidities. If we look at the other way at just how has the BMI changed over time, this is Jefferson data over the past 5 years, it's very stable. Although you can see an oscillation in the graph, which represents a seasonal variation of weight, but on average, it's extremely steady. And this is looking at the entire population of patients with dyslipidemia, hypertension, or diabetes. And the other thing to note is the mean is at 31. So it's in the obese category beyond the overweight category. And again, this is typical across the country. If we look, however, at clinical outcomes with individual providers, this is the data on 153 providers at Temple over 10 years. That with, 4 exceptions, all providers basically get consistent outcomes across the system. And we've, again, seen this everywhere we've worked, that healthcare providers at a system, on average, get the same results. There are very few people who are significantly above or below the average behavior. Until we got to Jefferson, which has 409 or 8 providers in the system that we had data for, but there tends to be much more outliers in this data set. We haven't explored the reasons for it, but it might represent different practice areas, different balances in populations, or different levels of economic security or lack thereof. But would be something interesting potentially to pursue. Another aspect of looking at diabetes is treatment outcomes. So what we looked at every institution is the formularies used to treat patients over the period that we studied them. And this is typical also. At Jefferson and Temple, they use the 14 diabetes drug classes and the 38 or so drugs that are in those classes. But what was interesting and a little bit different between the two institutions, if you look at either class combinations or drug combinations, Temple used a far smaller, almost 1/2 the number of drug combinations or class combinations that Temple did. But the other thing too to note, that the huge number of therapeutic combinations that are actually deployed by a set of physicians. And again, we see this everywhere. And so we would hope that as we titrate our patients across these different drug outcome or drug therapies, that their outcomes would be consistent. So looking at that, on this particular perspective, we looked at simply the number of medications the patient was on and what that average A1C level was for that patient population. And so at Temple and as well as at Jefferson, people on 0 or 1 medication were either below goal or at the average goal. But all other medical combinations of drugs, of 2 or more drugs, people were substantially and statistically significantly above the population average at both institutions. And again, this is true across the country. If we look at the population size who are on 0 or 1 drug, we see there is a difference. Jefferson has far more people at a potentially early stage diabetes than does Temple, but once you transition to the other stage, you end up in poorer control. So if we look at this in a little more detail, by the number of drugs you're on, we see that, I think this is Jefferson, so as we said, most of them are in 0 or 1 drug. But if we look at outcomes by class combinations, that basically metformin is at the average, and metformin glipimide or glipimide may get close to the statistical level of average, but all other combinations are basically invariant. If we look at insulin therapy in the two institutions, that we see a difference here where Temple in patients, in all patients, use about 35% of their patients are on insulin, but only 13% at Jefferson. But that may reflect the fact that Jefferson has, in the cohort we sampled, patients in earlier stages of diabetes. But what about outcomes of patients on insulin? Each institution gets almost identical results, where the A1C level is 8.7, certainly well above the recommended guidelines of the ADA and well above the guidelines that I think anyone has offered over time. If we look just at those patients in poor control where insulin is often indicated, we see again Temple uses twice the amount of insulin in patients with poor control than Jefferson. But again, those patients so treated have potentially identical outcomes and outcomes higher than what we would ideally like. Looking at some other perspectives of the newer agents, which have had recently reported clinical trials showing both cardiovascular improvements in diabetes, as well as cardiovascular improvements in the absence of diabetes and heart failure and renal disease, that we see the uptick in both institutions has increased steadily. But again, in Temple, that the rate of uptick or uptake of these medications and prescribing in patients with type 2 diabetes is much higher so far than Jefferson. So as comparison to diabetes care, the other part of the triad is blood pressure control. And if we look at population blood pressure control, on average, we see it's very good. This, I believe, is Jefferson. The Temple data was identical within 1 millimeter level. And we can also see the seasonal variation in blood pressure that's been reported many times over the years in the literature. If we look at similarly prescribing in hypertension, we see that there's even a richer therapeutic formulary available to clinicians than with diabetes, with up to 2,200 therapeutic combinations. So are we going to see the same challenges of so many therapies being less effective as the number with different therapy combinations? And basically the answer is no. This is just looking at, again, the number of combinations a patient is on. And patients on 0 medications or 1 medication have only a small change in mean blood pressure. And as the number of medications increases, there is a slight worsening, but not to the extent of change that we see with respect to diabetes treatment. So it's not just the sort of diversity of the formulary or relative inexperienced clinicians using certain combinations on only 1 or 2 patients and using a whole large variety of combinations infrequently. It is due to other factors. And if we now turn our attention to cholesterol, dyslipidemia, that we can look at whether or not patients over time at institutions have increasing cardiovascular risk profiles. So this is the 10-year cardiovascular risk as judged by the American Heart, American Cardiology pooled cohort equations. And on the left are the factors that go into it. And in this patient population, that it's basically steady at 15% over time, with maybe only a fractional 0.5% degradation or improvement over this time interval. And what's interesting, given that the 10-year risk on average is 15%, depending on which guidelines you go by, the endocrinology guidelines or the heart guidelines, the cut points in the decision treatment algorithms are at 5, 7.5, and 10%, which is far below this group of patients on average. If we look at LDL over time, it actually looks pretty good target of an average LDL of 100 in this population. But if we break it down by the number of major risk factors, which I've enumerated at the top, that we see actually as the number of risk factors increase, the LDL increases significantly and dramatically. And we can see this in another way when we look at risk category versus LDL. And I use these guidelines from clinical endocrinology report that subdivides the risk factors and risk categories by target LDL goals. We can do a similar analysis with American Heart goals using medications, but from a perspective of correlating EMR data with risk category and medications they're on, there certain challenges, and this makes for a simpler correlation. So here's the outcome from those risk categories at Jefferson. And we haven't yet broken down at Temple, but we did in 100,000 patients in the cardiology department in the Midwest, and saw basically identical results. For patients in low risk, almost everyone is at the target LDL goal. For patients at moderate risk, half the patients meet it and half the patients do not. And as we get to the higher risk categories, that fewer and fewer patients meet the target goals, at least as defined by the AACE. And as I said, if we look also at a similar perspective using statin intensities, we see people, high-risk groups that the majority of which should be on high-intensity statins, only about half of them are, and another large group are not on any statin therapy at all. So what is the impact of a quality improvement project? I'd already mentioned in the previous report at Tulane, looking at improving A1C, there was a 20% reduction in delays in A1C testing, and there was also some more modest improvements in the overall A1C level at that clinical site. We looked at another safety net hospital in Texas, Parkland Hospital, and they chose to look at poor control in their patients with A1C above 9, and they realized in the beginning they used a relatively small amount of insulin, and they worked on increasing the usage of insulin across the system. And we can see in the amount of insulin prescribed over time, as we move to the right of this top chart, that there's a steadily increasing use of insulin. And it had, with a phase lag, a dramatic improvement in the reduction in patients in poor control. And you notice that this particular patient population had an extremely large fraction of patients in poor control, being a safety net hospital with mostly charity care and dealing with a minority Hispanic population and a bilingual population. There were many challenges and barriers to overcome, but they did reduce from about 26% down to about 23% in the time we observed them in patients with poor control. And that was also reflected in the overall population A1C. So with this data from Tulane and also the data from Parkland Hospital, we collaborated with the folks at Tulane who developed a model of diabetes outcomes based on the ACCORD trials and projected if this improvement for the year before and year after the changes occurred, what would be the outcome in 5 years if the patients held the gains. And the findings were dramatic. Show here in the upper part of the chart that the patients who had A1Cs greater than 9.5 at baseline had up to a 50% reduction in cardiovascular death and 40% reduction in major adverse cardiovascular events. And even patients with more modest elevations of A1C above 8 had significant reductions in all cardiovascular outcome events. And so this is compelling in that quality improvement alone, using the tools and strategies we already have without awaiting any new research advances, can make dramatic improvements across our clinical populations to achieve better outcomes for all of our patients. And Greg, I think I stayed on time.
All right, thank you, Roy. If you could flip to the next slide, please. So I did want to talk a little bit about kind of previewing what's coming up here. This was, again, just kind of the kickoff meeting for a series of meetings that's taking place over the next 10 weeks. We're looking very much forward to hearing from each of our Diabetes Insight partners as to how they're actively addressing these challenges in diabetes and cardiovascular care quality that Roy's outlined, and that our partners have identified and focused on different targets across their institutions to make improvements in care coordination and medication adherence and addressing disparate populations. So the schedule is kind of currently active events that are coming up. I believe everyone's received invitations to these. We'll double check that and confirm. And the format's going to be a little bit different for this next series of meetings. We're going to have each health system and healthcare partner present for 30 minutes and then leave 30 minutes to discuss and engage on the topic. So we really want to encourage a more active discussion with our partners so that they can learn from one another, take some best practices, offer advice and suggestions and experiences to really accelerate the work that everyone is doing. Next slide, please, Roy. I do want to ask everyone to kind of reflect, though, on the many challenges wrought by COVID-19, and for our healthcare partners specifically to be prepared to discuss some of your experiences and solutions to these challenges in your upcoming learning meetings. And I think this is important because not only have these threats impacted the work that we're all trying to achieve here, I think they present kind of unique and significant challenges to diabetes management going forward, and something I'm kind of attuned to and interested to hear everyone's thoughts on as we proceed is the massive care access issues that COVID has wrought, and how those have exacerbated delays in routine care, such as just getting A1C tests, and as Dr. Furman kind of described, the importance of that from a process issue, that potentially leading to and other challenges leading to new prescriptions being down, new prescription starts. We're seeing data signals there, which is concerning as that leads to therapeutic inertia challenges. And I think maybe most importantly, the pandemic has certainly widened the gap in health disparities and has really shown a light on our collective need to tackle health inequities more aggressively. The fact that COVID-19 has disproportionately affected African American populations, care access issues, again, being a huge challenge with these disruptions. We want to start to talk about that a little bit and hear from you all. What have you found to be successful? What continues to be a challenge? Some things that you can share with one another that'll help us right the ship as we kind of exit the pandemic and then pick up the pieces with regard to all of these disruptions. And I think, though, if there is a silver lining to be found, it may lie in the fact that the pandemic has made us all realize, I think, how important it is to improve care coordination, both within and across institutions. And I think, learning collaboratives and quality improvement programs like this one are certainly an effective way to address these issues. And it's our goal, as Dr. Gabay mentioned, as ADA, to really sustain and expand these initiatives so we can continue to catalyze and accelerate your important work beyond this program and well into the years to come, because we're going to need, a decade of focus all together to address diabetes and start improving outcomes. And as Dr. Gabay also mentioned, I mentioned on the first slide that we're just beginning the early phases of forming a new quality improvement collaborative in the Chicago area. This is exciting for multiple reasons. Some in the early discussions I've had with these teams, they're working on similar challenges that you're all addressing here in the Philadelphia region. So, bringing their perspective to bear, I think, on what you're working on and having them hear from you some of the successes and challenges that you've had is really what this program is all about. So again, we're looking forward to seeing you all in the next several weeks over the course of these meetings. And again, we're capturing all of these and recording them, and encourage you to share this with your colleagues as we get them up online. And we've got a few minutes left. I don't see any questions in the question box, but we'll stick around a bit. And if anyone has anything they'd like us to answer, we can do that now, or we'll work on putting a response together later. But thank you all for taking some time out of your schedules this morning. Hopefully you've got a little caffeine in you now and get ready to start your day. So we'll stick around a bit and see if any questions come up. If not, we'll wish you all a good week. Okay, not enough coffee flowing yet for folks. So thank you all for attending. If you do have questions, you can email them to me directly. I'll make sure that Dr. Furman or Dr. Gabay can weigh in as appropriate. And thank you all again, and we'll see you in a few weeks.